Great. Thank you all for joining me tonight for this exciting webinar about expanding opportunities for vitreoretinal surgeons. I'll give you just a little bit of background about myself. My name is John Kitchens, and I'm a physician partner at Retina Associates of Kentucky in Lexington, Kentucky. I've been out now for 9 years in private practice retina with a busy fellowship. I have 4 other wonderful partners who help to support us, 3 of which are surgeons and 2 of which are medical retina specialists. And we serve the state of Kentucky, particularly the eastern part of the state, which is about a state of about 40,000 square miles and 4.4 million people. So what we're going to talk about tonight in an overview of things, first of all, my financial disclosures is listed here on our slide. We're going to talk about expanding opportunities in vitreoretinal surgery, and particularly we're going to focus on ambulatory surgery centers. And I think this has been a real unique opportunity for us, and it's been an opportunity that's been created courtesy of a more affordable, fantastically efficient machine that is reliable and really has some tremendous performance with it. And so I'm going to tell you about how we've utilized this new machine and how we continue to utilize this machine to create opportunities for us. So the layout of this talk tonight is basically going to be an introduction to our practice, a bit about our story or my story in integrating into ASCs around our region, some keys to success from a surgeon's perspective and keys to success from a facility's perspective. It really does have to be a win-win between both the surgeon and the facility to make this as beneficial for each partner as possible. And then a roadmap to integration and a Q&A. So a little bit about our story. So we have 10 satellite offices in the state of Kentucky. We have 1 main office in Lexington, a 2nd main office in Louisville. And when I originally started here, we had 6 offices scattered around the center part of the state of Kentucky. And we only operated at our hospital next to our office. And what I found is that we had a variety of cataract surgeons who own surgery centers, not only in Lexington, but in Louisville and in the eastern part of the state, primarily Ashland, that really wanted their patients taken care of in their facility. The problem with this, though, is that at the time when I started, the costs were just simply prohibitive. We really couldn't have a 1 or 2 or even 4 or 5 person anterior segment surgery center afford $200,000 to $300,000 worth of capital equipment. They weren't really willing to make that risk. So what changed? Well, in 2010, our hospital went from existing technology, the Accura system, which was a very robust system, and upgraded us to the Constellation system. But at the same time, that system was recalled, voluntarily recalled, and so we had a chance to demo a variety of equipment, including the Stellaris PC and the Doric Associate. And so we had a real chance to see what was out there, to see the landscape. Now, between 2010 and 2011, Synergetics, a company that I was very familiar with and really liked the reliability and quality of their products, had launched a unique pack that would fit the Accura system called the VersaPack. And so we went from having $500 pack prices for our Accura system down to having $300 pack prices, which created an opportunity now to go to our local surgery center here in Lexington and say, we're really interested in partnering with you and doing some surgery there. So we were able to obtain a refurbished Accura system, and with the VersaPack, actually begin doing surgery for the first time in an ambulatory surgery center here in Lexington. That surgery center had 7 cataract surgeons, of which 4 or 5 became loyal referring doctors to us, in many ways because we were now operating in their facility. And so in 2012, when the first VersaPack was released, About that time, our Accurus that was refurbished was getting a little bit long in the tooth, and so I said, let's upgrade to the VersaVit 1.0, and they very happily afforded that, which at the time I believe we paid about just under $30,000 for that, but the pack prices remained stable at $300 per pack. And so we quickly adapted and integrated into the surgery center with the VersaVit 1.0. Well, about 6 months later, one of our satellite clinics in Ashland, Kentucky, 2 hours to our east, came to us and said, we don't send you probably 30 to 40% of the patients, or we don't send you a third of the patients that you could be operating on because they just simply cannot travel 2 hours to Lexington to have the surgery. We think this is a real shame. We'd like to have you operate closer to home. So we said, we'll take this experience from our surgery center in Lexington and we will duplicate that in your surgery center. And that's been a really tremendous opportunity for us. We've operated out there now for just over a year. We go down 1 day per month and do between 10 and 13 cases. And the VersaVit is the only machine that we have there. We take on a variety of very tough cases, bad diabetics. We do a lot of silicone oil. And we'll talk a little bit about that later. Around that same time frame, we opened a second main office in Louisville, Kentucky, and the fact that we actually our office owned a VersaVit, we were able to integrate the VersaVit into a surgery center there that wasn't currently doing retinal surgery. And then in 2014, with the VersaVit 2.0 release, we've been able to upgrade all of our systems very, very affordably to the VersaVit 2.0 with higher cut rates, and it's really helped enhance our patient care and speed of our surgery. So that's a little bit of history. Let's talk about some of the keys to success and what I found in setting up these 3 separate ambulatory surgery centers. And I really think that the keys to success have to be a win-win and win between surgeon, supplier, and facility. The surgeon has to be efficient, they have to be cost conscious, and they really do have to be dependable. They have to be dependable that they're going to bring as many cases as they possibly can to that surgery center. It's very hard in the beginning as a surgeon to start operating someplace new. And so one of the mistakes I found was that I started in at our initial surgery center a little bit on the slow side, easing into things. And I can tell you that what I learned from our second surgery center, where we kind of had a baptism by fire, starting with 7 or 8 cases the first day that we actually started operating there, it helps to book a lot of cases, even if they're straightforward cases such as macular holes and epiretinal membranes and vitreous hemorrhages, to really get your clinical staff up to speed. From a supplier standpoint, you want inexpensive equipment in a surgery center because you're referring doctors, and if you're an owner, you're going to be footing the bill. And so we'll see a little bit later how pack prices impact that and capital acquisition prices impact that. You want your equipment to be reliable. A lot of surgery centers aren't going to want to buy a backup machine to place in the surgery center for you to have. That's an additional cost. So you really need to know that that equipment that you have is not going to break down. And you want a supplier that's customer-focused and listens to you. From a facility standpoint, what they want is, or what you should want with them is you want them to be efficient. Why are you operating in a surgery center or a hospital? Well, in many ways, it's to gain efficiency. Turnover time's much better in our ambulatory surgery center than it is in our hospital. You want them to be flexible. I never have a problem getting a case on before clinic at our surgery center, whereas at our hospital, it's oftentimes difficult to get blocked time. And you want it to be rewarding in a way that's garnishing you more referrals from your doctors that operate there. And if you're a partner, you want it to be financially rewarding. So let's take a look at the VersaVit and see from a performance standpoint how it stacks up and how it can really perform along the same lines as some of the much more expensive pieces of equipment. So when we look, we can see the price point of each of these, and we'll get into the price point a little bit more later, but we can see that compared to the Constellation and the Stellaris, it's a half to a third for the basic unit. And the pack price, similarly, is anywhere from 25 to 33% less than either of its two main competitors. The Associate certainly comes in at a very similar unit cost and similar pack price, but there may be some inefficiencies particularly with the technical staff that you have and turnover and things such as that. When you look at the performance parameters such as cuts per minute, vacuum, the type of cutter that you're using, the size of the cutter, including the 20, 23, 25, and 27 gauge, you can see pretty much across the board all the machines have very similar parameters. When we look at the ability to control duty cycle, which I really think is critical for rhabdomatogenous retinal detachments as well as dense fibrotic tissue, you can see that the first three, the Versavit 2.0, Constellation, and Stellaris, have duty cycle control. With the Versavit, you have your choice of a variety of cannula trocar systems, including their stealth and their one-step. And you have your choice of a light pipe. You can choose in your custom pack to have a midfield light pipe or a wide field light pipe, which is really nice. Now, many people say, well, it doesn't have certain things. What about reflux and what about fragmentation? Well, I'll tell you that I found this a very easy workaround in our ambulatory surgery center in that for reflux, I'm simply able to have our surgical scrub pinch the tubing to our cutter or our soft tip, and that acts in a way to induce reflux. Very, very easy. We used to do it in the old days with our Accura system when we had trouble with the reflux working. And as far as fragmentation, I have the ability pretty much readily to determine who I'm going to need to do fragmentation on in advance. And if I'm going to have to remove dense nuclear sclerotic tissue, I just simply schedule that person for our hospital. If the person has some, a quarter of nucleus left or only cortical material, I find that 25 gauge cutter systems work for that and work rather well. Interestingly, Synergetics has in development and soon to be released a vitrectomy probe that will actually function for all intents and purposes much like a fragmentation handpiece, and that's going to be a really nice thing to be able to use when you have more than a quarter of very dense nucleus present. And the real thing I want to look at on this slide, though, is the setup time. And this is something that I did not appreciate going into this, that setup time would be so incredibly critical. But that is really what's the biggest drawback to a quick turnover. And when I found comparing our hospital to our surgery center, it seemed like it would take an additional 10 minutes to turn over. And I sat one day and watched what was taking so much time in each setting. And really what it came down to was the setup and the cleanup time was so much quicker with the Versavit versus what we used in our hospital, that it allowed the nurses to get the machine set up so they could send the circulating nurses to go retrieve the patient and bring them in the room. That it really was very fluid and very easy to turn the Versavit over. So what about performances as far as from a surgical standpoint? Well, you can see that cut rate has been dramatically improved with Versavit 2.0. It's gone from 2,500 with 1.0 to now 6,000 with 2.0. And this stacks up with the competitors really nicely. Now, I've got to admit, I was the first one to say I loved my Versavit 1.0. And I said, gosh, you know what? I really don't know if I need a higher cut rate. And I especially don't know if I want a higher cut rate if it's going to decrease my flow and if it's going to make my core vitrectomy take much longer. But what I was shocked about with the Versavit 2.0 is that even though they increased the cut rates from 2,500 all the way up to 6,000, that actually in the sweet spot, which I feel is 4,000 cuts per minute, you get incredible flow. And this comes from two things. Number one, duty cycle control, where you can have a port-biased open vitrectomy probe so that you're getting more flow, you're closed less often. And you can see how it compares to the Constellation. My core vitrectomy, amazingly, was quicker than what I experienced with the Constellation. And I was overwhelmed by this. The second thing that I think helps is they've got a slightly bigger port size for their 25-gauge cutter. So what won me over was what I expected to be the drawback, and that was the fact that the core vitrectomies went so much quicker. And I found that I could do a basic core vitrectomy in a patient in around 2 to 2.5 minutes, which was a lot faster than what I found with VersaVit 1.0, and actually significantly faster than what I was finding in our hospital with Constellation. So we can see here how Synergetics has really continued to push the envelope with this machine. And what I really appreciate is that they came out with 1.0 in 2012, and I was happy with it, but I thought they could do things a little bit better. I think others did too. And they came right back with the upgrade to version 2.0 in 2014, addressing almost every issue that we had with it. In 2014, later this year, they're going to release the Photon EX. I have it labeled as Photon 2.0 here. It's going to have a variety of different light filters with it. It's going to be integrated and fit under the VersaVit really, really nicely. And then later this year, probably in November or December, they're going to release a very elegant silicone oil infusion and extraction device that will be able to push silicone oil into the eye, remove silicone oil from the eye via 25 or 23 gauge cannula systems. And so it's this continued innovation, not just from a software standpoint, but from a hardware standpoint, that's made me a big fan of this system. So what we see is that we have great performance, the 6,000 cuts per minute, the equivalent 500 millimeter aspiration, duty cycle control, the next generation photon. We have tremendous efficiency, particularly when it comes to setup and turnover of your room, combined with cost savings. Unit cost being $25,000 roughly here in the United States. The pack cost running anywhere from $300 to $350 with an upgrade from version 1.0 here in the U.S. to version 2.0 of only costing you $5,000, which is amazing. I mean, this is easily a machine that Synergetics could come out with and said, guess what, you'll have to buy a whole new machine. We've now fixed some of these issues with the first machine. But they didn't do that. They said, we're going to modify your machine. We're going to replace your machine for a low cost, and we're not going to increase your pack cost. And so that just really blew me away. And then the versatility of it. The weight of the machine is 25 pounds. It's very, very portable. You have the versatility of having a variety of light pipe choices, and you can customize your packs. So let's look at a couple of surgical videos here that we have to just kind of show the benefits of the VersaVit 2.0. So one of the first things that I love is the cannula trocar system. Synergetics is continually refining their cannula trocar systems. You can get valve cannulas, you can get non-valve cannulas, you can get valve cannulas that you can remove the valve from the cannula. They go in great. I oftentimes vacillate. I use the stealth blades in one surgery center. I use the one-step or the flat blades in the other surgery center, and I love them both. Here we can see my core vitrectomy settings. Usually I'm going with a cut rate of about 4,000 to 4,500 cuts per minute, aspiration of 500 millimeters of mercury, and port bias open, and I really find that gives a really nice, fast, and efficient core vitrectomy without having a lot of traction on the peripheral retina. Here we can see how efficiently it's removing this vitreous hemorrhage as we just kind of cut in this diabetic patient. And it's very, very efficient. We can see the improved flow. It's 40% greater at 3,000 cuts per minute, 28% greater at 4,000 cuts per minute. And I pretty much routinely for a core vitrectomy will keep the cuts per minute at 4,000. And the only thing that changes when I push down my foot pedal is going to be my aspiration, running anywhere from 50 millimeters of mercury at treadle start to 500 millimeters of mercury at full treadle. We have tremendous fluidics. We can see here I'm doing an air fluid exchange, and I think it's better than the VersaVit 1.0 as far as the fluidics are concerned, both in fluid and in air. I run my infusion pressure now because of the higher cut rates that I'm able to achieve in a much more stable environment. I run my pressures anywhere from 20 to 30, whereas in the past I'd run them at 35 or 40. Here we can see induction of a PVD. The larger port on the vitrectomy probe allows you a greater purchase of the vitreous, and so I find a lot of times when I have to induce a PVD, I get it on the first try. I give it an extra second when I'm over the optic nerve and aspirating to be able to grasp that vitreous, but you get such a firm grasp of the vitreous that almost every time when you are a little bit patient with it, you're able to get your PVD on the first try. Here we can see just how efficient it is at removing ICG from the eye. Just right now, and I'm actually cutting, I'm not aspirating, and that removes the ICG that fast at 4,000 cuts per minute. The most impressive thing, though, is when you're shaving over detached retina. And when I get over detached retina, I don't change my cuts per minute. I keep it at 4,000 or 4,500, but I do go to a more closed duty cycle so that my port is closed more often. And you can just see the tremendous stability of this retina as I'm removing vitreous over these tears. It remains very, very stable. If I get a little bit more movement to my retina, I may back off my aspiration a little bit, or I may increase my cut rate or a combination of both. But I find very rarely do I have to have this occur. And it's really nice for our nurses. We're not switching modes. I can actually change this via my foot pedal with just a click on the right rear button from a port open to a port neutral to a port closed. And nothing else has to change, and I can fluctuate between those myself, so I don't have to ask the assistant to change me as far as that goes. Once again, here we are trimming over this detachment, and that duty cycle control really helps. Here's a patient that had some old blood in their eye, and we can just see the marked efficiency that we have with removing these vitreous debris from this patient. You do have to tend to go a little bit more into the vitreous to remove it, but that to me signals that it creates a lot of stability in the eye. And so it's only really when you've engaged the vitreous that you get this really, really efficient and very stable flow. When you're in fluid, once again, the eye is very stable, but if you're in fluid, you're not going to be removing as much vitreous as effectively. I find that there's very little traction on the peripheral retina. And in fact, I find that I have no more tears with this machine doing very extensive peripheral vitrectomy than I do with my Constellation in the surgery center. So moving along and looking at the really challenges, the key challenges to integrating retina surgery into an ASC, the first thing is the cost. When we first looked at this, the capital costs were going to be about $200,000 and the pack prices were going to be $500. That stopped our integration right there with every discussion that we had. But once we overcame the cost issue, then we were able to transition into operating in a new environment. Now, there were a little few obstacles there. The first thing was kind of having a slower rollout. When I first started in our surgery center, I'd book 1 or 2 cases a week, and really I found that our staff couldn't get the hang of things right away. New equipment. Challenges have changed. Basically, if you're a surgeon who's operated in one environment for 5, 10, or 15 years, it's tough to make that change. It's tough to go to a new place where the microscope may be a little bit different. The system is different. These are changes, but I will tell you that it's one of the most rewarding things to be able to start in a surgery center and look back and go, we established that. And honestly now, it's hard not to take cases to the surgery center. It's so efficient. And then one thing I didn't really appreciate, and this is still something we're adjusting to, is our office workflow, scheduling. Now, what cases do we do and where do we do them? I've got some really great surgery schedulers who are really starting to get refined as far as knowing that we want to take our less healthy diabetic patients to the hospital because they're going to be longer cases for one, but two, they may need the assistance of our inpatient hospital doctors. And what referring doctors like their patients done well or done where. And so, if we're operating in multiple different surgery centers here in town, you want to be very cognizant that you don't want to take one doctor's patient to a competing doctor's surgery center. And that's pretty easy. That's a decision that I can make and something that I can kind of dictate. So Let's delve into the cost of things. When we look at the acquisition costs, we can see that the capital purchases include a vitrectomy machine, a laser. You're going to have a backup unit. You may have to have a microscope. You're going to need a wide-angle viewing system, and then you're going to need other instruments such as cryotherapy. You're going to need buckles and other things such as that, and some instrument trays. You're going to have costs for disposable products, including a front table pack, a back table pack. You're going to need forceps on individual cases, laser probes, and you may need disposable viewing lenses, or you might reuse your viewing lenses, which will provide you with a little more upfront costs, but less disposable costs. And then you're going to have indirect costs such as anesthesia, staff, and non-salary overhead. So let's look at the first scenario, and that is strictly looking at capital equipment purchase here. If you spend $125,000 for an expensive vitrectomy machine, integrated laser and whatnot, $11,000 for cryotherapy, $2,500 for instrument trays, and $95,000 for just a refurbished microscope, video recording system, and your wide-angle viewing system, you're going to come in at about $250,000. Now, if you want to get really fancy, you can have a new scope, which is going to probably add an extra $100,000 onto this total. And I can tell you that that's not going to be the most palatable option for a surgery center that's not currently doing any kind of retina. What about the second scenario? So let's say that you're going to go with a vitrectomy machine, a more affordable vitrectomy machine with a laser. You're going to spend $50,000. You're going to spend $11,000 on your cryo, $2,500 on your instrument tray. And then let's say that you're going to cut out the video recording system, but you still want to have a refurbished microscope and a viewing system. Well, you can knock off about $100,000 from that large capital acquisition and take it down to $138,000. Once again, this is going to be a little tougher for a smaller surgery center, maybe a surgery center that might be struggling or one that has 3 or 4 surgeons working at it. And so it may be something that the capital purchase price inhibits your integration into the surgery center. What about scenario number 3? So let's say that you're going to get this, once again, less expensive vitrectomy machine with a laser for $50,000, $11,000 for cryo, $2,500 for instruments, but they already have a microscope. And most surgery centers that are doing cataract surgery will have a microscope that can be converted over very, very affordably to a vitreoretinal surgery. So now all you really need is you need a viewing system, which is $25,000. Now you're under $100,000 getting started in the surgery center. Now let's say that you use a disposable viewing system. And so they now have wide-angle viewing systems that are disposable. So you totally eliminate the microscope and the viewing system cost. Now you really only have the vitrectomy machine and the laser along with cryotherapy and your instrument tray. Now you're down to $63,000. And this is where we were at when we did our surgery center in eastern Kentucky, and they jumped at the opportunity. So you can't really uncouple the capital acquisition costs from the cost per case of the disposables, because what you really need to do is you need to justify the purchase with the number of cases and the profit per case that you have. So this is kind of just a typical spreadsheet or typical outlay for a standard direct case cost. So $400 roughly for a vitrectomy pack, wide-angle viewing system pack at $85, $150 for forceps, and $150 for a laser probe. You may not use laser probe and forceps on each case. $25 for the back table pack, and then $30 for miscellaneous things. That comes in about $840. When you take into account your salaries for staff and your non-salary overhead, you're right around $1,300 per case. So you really need to know what you're getting paid per case. So if we look here at the diagram, we can see if we're doing a Medicare case, roughly per 2012 numbers, we're getting paid $1,545 on average for a facility fee. For a non-Medicare case in our surgery center, it's about $1,905. I split the difference and said $1,725. So if we take that $1,725 reimbursement, minus the $1,295 in cost, we find that we get an average of about $430 in profit. Keeping in mind that we've already outlaid anywhere from $60,000 to $230,000 for capital expenses, it's going to take a while to be able to pay this off. So what happens if you use a less expensive vitrectomy pack alone? So let's take that $400 number and let's take it down to $300. And let's say that you've got a very shrewd surgery center manager who's able to negotiate down forceps to $125 and laser probes to $125. And then let's also add in the fact that this is an efficient vitreoretinal surgeon. This is not someone who takes an hour to do a vitrectomy with a membrane peel. Let's say this is somebody who takes 25 minutes, 20 minutes to do your standard vitrectomy membrane peel, or 20 minutes to do a vitrectomy with endo laser for a diabetic case. So you have less staff time. Now your total expenses have dropped to $1,045 per case. So it's coupling not only financial efficiency of the machine, but surgical efficiency of the doctor to increase your profit margin. And so we can see here that if we also take more non-Medicare reimbursed procedures to the hospital, and we shift that reimbursement up just $100 to $1,825, combining that, that increased reimbursement with greater efficiency on the equipment and the surgeon end, we're actually able to make $780 of profit. So if you kept your capital expenses low, let's say on the low end, the $63,000 end, you can see that you can have this vitreoretinal equipment paid off in 81 procedures. So 81 vitrectomies, and all of a sudden now the surgery center has broken even, and they're actually now profitable per case. And I can tell you that when you do that, if your cataract surgeons own that surgery center, they are going to be extremely happy with you and with what you're bringing them. Let's look at just the opposite scenario here. What if you have a more expensive vitrectomy pack? Let's say it's a $450 pack. Let's say you haven't negotiated better deals on your forceps or laser probes. And let's say, that just for argument's sake, that you have a less efficient surgeon. Surgeon wants to take a little more time, and basically they're gonna expand their time by probably about a third. So you're gonna have a little bit more overhead. It's very easy to push your total expenses of disposables and indirect case costs up to $1,445. What happens then if you're doing more Medicare cases, let's say for argument's sake, and your reimbursement's more closer to that $1,650 level with that higher cost? Now your profit margin is $205. And so you can see if you spent a lot of money on capital expenses, let's say you really laid everything out, bought the machine, bought the refurbished scope with the recording system, and really splurged on everything, it's going to take you over 1,000 procedures before you break even. Now, I can tell you that that oftentimes when you're integrating into a surgery center, you don't go whole hog and leave the hospital and just take all of your cases over there. What happens is you have a mix, and you're able to pick and choose what cases you think are most appropriate for operating in a new environment. And so it'll take you forever to basically break even, and you'll have some unhappy referring ophthalmologists if they're footing the bill for this expensive equipment, and they don't see that it's going to break even anytime soon. So when we look at the challenges, we can see that the cost of the equipment is no longer a challenge. The transition, basically scheduling basic cases such as macular holes and epiretinal membranes, vitreous hemorrhage, but scheduling a lot of them per day when you're initially operating there will really ramp up your staff's technical skills as far as turnover times and understanding the equipment and things such as that. And you're really able to merge this success and what you need to be successful by having the right equipment. And that's an efficient setup that costs are reasonable, that's reliable, safe, very easy to troubleshoot. If you have to turn the machine off and turn it back on, it boots in less than 10 seconds. It's very, very consistent case to case. and it actually performs unbelievably well. High cut rates, very stable retina, really nice fluidics. And so it's really this combination that leads to success from an equipment standpoint. And we can see all of these things are really mastered by the VersaVit 2.0. We have reliability, we have efficiency, and we have performance. When we talk about the challenges of change, really new equipment is going to be new equipment. Operating in a different environment is going to be operating in a different environment. If you are a confident surgeon, I find that it can still challenge you quite a bit. And so I would just say that you really want to stick with it. Don't give up when you're starting there. Schedule some of those easy cases and make sure that you dedicate yourself to actually giving it a true chance to work. But the financial side of things, which is the biggest obstacle now, seems to be overcome with operating in a surgery center. One last slide, basically on surgeon analysis, and I call this a surgeon analysis slide. If you look to the left, you'll see what the surgeon should be looking for, or what the ASC should be looking for, and then to the right, what the surgeon should be looking for. So I think surgeons, when they go and evaluate a surgery center, they want to look for surgical efficiency first and foremost. I think they need to look for cost efficiency. They need to see if there's a low complication rate, commitment to the ASC, that retina surgeon is going to bring their caseload there, that surgeon's ethical, and that surgeon's going to be affable, that the staff is going to like them. Surgery centers, especially single surgeon or a couple surgeon surgery centers, are a small environment. You want to have the staff like you, because they're going to talk to the cataract surgeon, and that could affect his referrals and his relationship with you. From a surgery center standpoint, opportunity, they want to look at the opportunity to bring you in, the efficiency, your availability, your commitment to doing your retina cases there, location, the possibility of ownership, and then what kind of leadership is present with that surgery center. So finally, on rolling this out, just a brief outline of how to think about things. First of all, ask yourself, are you an ASC surgeon? Are you efficient? Are you comfortable and confident operating someplace new? Estimate your average case time, or get your average case time from your hospital and look at it. If your epiretinal membrane and macular hole case time is 30 minutes or so, I think you're a perfect person to be an ASC surgeon. You're definitely not going to lose money for that surgery center as long as you're cost conscious with the equipment that you choose and the instruments that you use. Is there an opportunity in your area? Is there an ASC available? Are they already doing eye cases? Do they have busy cataract surgeons that are going to refer to you? And do they have time available? And then what are the benefits? What are the financial opportunities? Is there an ownership opportunity? What about the increased caseload? Are there going to be new referrals coming in? Is there going to be improved efficiency? Are you going to be able to do the same number of cases that you do in a day now in a half a day, and have a half a day for your own time or for clinical patients? And is there a better patient experience? Now our patients come back raving about their experience at the surgery centers we work in. Very, very pleased at the efficiency and things such as that. And then you want to next approach the ASC. So once you've weighed these first three things and you decide, I do want to look at joining an ASC, approach them. Go to the cataract surgeons that you know there. Talk to the ASC director. Say, I'd like to come in. I'd like to watch and observe the flow, how patients come in and are checked in, how efficient is the turnover. Where do the cataract surgeons operate? Where do the other surgeons operate? Evaluate their equipment, because this will allow you to say whether or not you can utilize their microscopes, some of their trays, and some of their other things. It can ultimately save them money. And then the fifth step is to involve industry. I can tell you it's really great to have a person in industry, a sales rep who knows how to go through and knows the equipment that you may not even think that you need, that they know because they've done this before, to look and outline exactly what you're going to need from an equipment standpoint, and to provide that surgery center with a very streamlined and efficient set of equipment that they need to buy for you. And then start your surgery at the ASC. Once again, start with the basic cases, but don't ease into it. Jump right in as far as that goes. I'd like to bring up one other possibility before we get to the Q&A thing, and that's something that we're working on in our hospital. In the United States, we're having this this tremendous transition to cost-conscious care. And the hospitals for the longest time, I think, have lagged behind this attitude of trying to do things as cost-conscious as possible. And we are actually to the point now where I think we have the opportunity to start operating in our hospital utilizing two systems, which is quite unique, where we'll actually utilize a more cost-conscious system, the VersaVit 2.0, for the basic cases, the epiretinal membranes and the macular holes and whatnot that we may have the opportunity to do at the hospital, and save them $300 to $400 to even $500 per case. But when we have that, case that needs silicone oil, or that case that's going to be the difficult lensectomy case or whatnot, we actually have a machine that is more expensive that we can do those cases on. And so we call this a one-in-one. And our hopes are that we actually, by using a more cost-conscious machine, may actually drive down the pack prices from the more expensive machine. So in some instances, competition can be really good and can level the playing field and can get you better deals on not only your packs, but your disposables and laser probes and things such as that. So with that all being said, I appreciate you tuning in. I'm going to go through a few questions and answers questions that we have here and see if I can provide you with any answers. Let's see here. So the first question that we have is, how do the overall fluidics of the system compare to other systems? I've had the great opportunity to utilize, once again, the other three main systems along with the Accurus here. I really feel like the fluidics as far as stability in the eye, the stability of the globe, are on par with every other system, if not a little bit better. Not by virtue of the actual flow through the cannula, but by the fact that the duty cycle control and the high cut rates create such a stable environment. And once again, I'm able to run my pressures at 20 to 30 instead of 35 to 45. So I think the fluidics are absolutely fantastic. Once again, my core vitrectomy times are very, very low, shockingly low with the VersaVit 2.0, and actually even better than the VersaVit 1.0. So I think the fluidics stack up against any of the other systems that are out there. They're not as finicky. It's very basic. It's kind of your standard BGFI. There's no dynamic compensation that happens. It's not over-engineered, and so you don't tend to have a lot of the potential issues that you can have from something that has a lot of moving parts. It just works. Second question, are you regularly changing duty cycle throughout the case? How is duty cycle adjusted in the machine? That's a great question. So I tend not to change my duty cycle throughout the case if I'm doing a straightforward vitreous hemorrhage case, or if I'm doing a straightforward macular hole, or something that I really want to do just a core vitrectomy on, where I don't have to deal with shaving and detached retina and things such as that. So I'll keep the cut rate at 4,000 to 4,500 cuts per minute, the aspiration at 500 millimeters of mercury, and I'll keep my duty cycle open, and that creates a really efficient flow of vitreous out of the eye with a very stable environment inside the eye. However, if I'm working over detached retina, or I want to shave in a diabetic patient, then it's a very easy process of just simply clicking my my right rear heel button to change that duty cycle. You can adjust this to any button on the machine, but basically I just click to the right and rear. It's a very tactile button, so you can feel it with your heel. You don't even have to move your foot off the pedal, and that basically cycles the machine through open 50-50 duty cycle and then a closed duty cycle. And there's a corresponding sound each time you click it, so you know how many clicks you've moved through. And then if you look over at the machine, you can see it as an O, a 50, or a C to basically indicate, where it's at in the duty cycle, or you can ask the nurse. What percentage of your procedures are you performing with the VersaVit is the next question. Another great question. In the Lexington market, where I operate about 50% of my cases in the hospital and 50% in the surgery center, I would say it's pretty much 50-50. When we go into Eastern Kentucky, it's the only machine I have there, and so I do 100% of my cases with it. And this is really this kind of walking the tightrope without a net is where I've really come to appreciate the fact that VersaVit is a fantastic machine. I don't know that I would have ever taken the training wheels off of it and experienced the way that I experience it in Eastern Kentucky, where I have my partners who sign up really tough diabetic tractional detachments, patients who need silicone oil, and other things such as that with this machine, and it performs amazingly well. So I can say that there I do 100% of my cases, and they are the most difficult cases that I do. I really enjoy working with it. It reminds me of taking pictures. I do a lot of photography, and I take pictures with a Leica camera. We have a lot of very manual controls, and you really feel in tune with the picture-taking process. I feel the same way about the VersaVit. It's so simple, and everything is easily adjustable on that machine as far as your parameters are concerned, and it just works. Next question, are you using VersaVit exclusively in your operating room, or do you have another system as well? If so, how does your staff handle toggling between the two systems? In our surgery center in Lexington, we do have a VersaVit and an Accurus. I actually haven't used the Accurus in about a year and a half since we got the VersaVit. So we just pretty much do the VersaVit exclusively in that environment. What we're hoping to do in our hospital setup is to be able to have both systems set up side by side, not prepped and draped, but indicate on our scheduling, surgery scheduling sheet to say we want to do VersaVit for this case, or we want to do Constellation for that case, and then the staff will know which one to set up as far as that goes. And so we're starting the process of training them now to do that. Both machines can be set with a Y adapter to run off the gas that's in the room and not have to unhook a machine or move a machine out of the room. So I think that'll be very efficient. I think it's just going to be more of an issue of scheduling the cases and letting people know which machine we want for which case. And the final question that I have here is, does the system offer silicone oil injection capability? Right now, I have a standalone silicone oil infusion setup. It's an older setup that we acquired, and we have this in a couple of different locations. But in November or early December, Synergetics is going to have a standalone, very elegant, attached to the machine, very small silicone oil infusion system that's going to work extremely well. That with just a simple flip of the switch will activate, will run off the pressure capabilities of the VersaVit machine, and will infuse silicone oil very, very effectively. So I've played with this. It's amazing that they can engineer this into an existing machine in such a small form factor. So right now what I have is a cart that has probably a 1 foot by 2 foot by 6 inch tall device that infuses or extracts silicone oil. This is going to be literally about the size of two boxes of matches, two tiny boxes of matches, or two lighters on top of one another, and it will be integrated into the side of the machine, and it does a fantastic job. All right, I'm looking. I don't see any other questions coming up here. If there are any other questions, I'll refresh here and see. All right. Well, it looks like we've answered all the questions. I appreciate everyone taking time out of their evening to listen to this webinar, and look forward to your experiences with VersaVit and working in surgery centers. Thank you.